So I think we can start with the second part of this instruction course, where we'll have two small talks about how to manage these cases when they have a retinal detachment.
Thank you. Yeah. So the most dreaded complication here is a retinal detachment, and despite your therapy, some of your patients are eventually going to land up with that. I think this is the other one, Dr. Vinod's presentation. Can I have my presentation first? It's
Please put on Dr. Rohan's.
The file is number 2. Number 2, Dr. Rohan CHAWLA. Just put that on. Yeah, thank you. So if you do have a patient with a detachment here, it's not at all easy to manage. But just from some of our experience, we'll share some of the surgical tips. I would go ahead with some of my cases, and then Dr. Vinod would add on some tips to that. Okay. So this patient had initially this peripheral lesion with vitritis. We diagnosed as acute retinal necrosis and planned the same way as we have described. We started IV acyclovir and started Vicelon. Patient started improving, but then detached. So then what we planned is, in many of these cases, I generally prefer to put an encerclage, because many times you are not able to remove all of the peripheral vitreous, and then vitreoretinal surgery under silicone oil. So just to show you this surgical video. So these patients tend to develop these large necrotic breaks, and then these areas of traction and some folds. So you have to clear the vitreous over it, and the vitreous is also like not a very normal vitreous, and it can also be shitic. So you have to remove that last layer of shitic vitreous, and nowadays I also stain with BBG and try to remove the ILM over there, so that you are very sure that you have removed the vitreous or any membrane. And at the edge of the break, the breaks there, you tend to form these folds, or this the break is turning over. So there also you have that membrane. So it is a good idea to try to peel that sheet of membrane and try to make that area as traction free as possible and as flat. And then you can also peel the ILM at the posterior pole and drain from those holes. If required, make a separate retinotomy. Otherwise, you can just drain from that and do a very, very broad laser. So the main thing is that the vitreous is again inflamed, so not a very normal vitreous. Remove it as far as possible. It is shitic. Look for the posterior second layer of vitreous. Do a PV triamcinolone staining. Do an ILM staining. Remove that last layer. Remove the ILM at the posterior pole. Extend that ILM. Peel up to the edge of these large breaks. Try to unroll that edge of the break, and that would release the maximum traction. And then drain and do a very, very broad laser and inject silicone oil. In this patient, we were able to remove silicone oil eventually. This is with photograph with silicone oil in C2, but okay, the last photograph is not there, but we were able to remove silicone oil, and now the patient is one-eyed but maintains 6/60. So this is a young boy with ALL, and again you see these large necrotic breaks over there, and some of them forming folds. So that layer of vitreous which still sticks on despite removing the main core of vitreous, you need to remove that, and you need to stain, and more ILM you remove, you make the retina more mobile. And you see again here that at the edge of the break where the rolling is there, if I can peel off the ILM over there, I'm quite sure I have removed whatever membrane is causing traction and causing that break to remain open. So that has probably increased the success of my surgery and increased the chances of removal of oil and still not landing up with a redetachment. So you do that. You see that rolled edge needs to be taken care of. Here these folds are there, retina is sticking on. So do a cautery and increase the size of the retinotomy. You anyway have such large break. You do a retinectomy over there. You have to have a retina which is not under traction, and then go ahead with that broad laser and inject silicone oil. Even in this eye, I was able to remove silicone oil, and this boy developed detachment in the other eye also, which we caught a little early and did a surgery, and we were able to salvage vision in both the eyes. So this is a very advanced case where the small boy had developed this detachment, and despite therapy, patient had a lot of inflammation and lot of subretinal changes had developed. See, a lot of these membranes in the periphery we tried to peel. unless we remove as much traction as possible, you are going to land up with a redetachment. And here I felt that the whole choroid itself had been dragged posteriorly. There were large subretinal, even bands and sheets of subretinal membranes, where I had to remove them through making some retinotomies. This was a band just next to the fovea. I had to make a retinotomy just close to the fovea. I'm doing this aggressive surgery just because this was the only eye of the patient. Otherwise, maybe you could also have just left it. But those subretinal bands were removed. We can see them better in retro. But still, I felt that the retina is not very mobile. So I tried to inject PFCL, but that PFCL went subretinal. So that means the traction is still not totally resolved. You remove that PFCL, and still if the retina is not fully mobile, you are not left with anything. You have to continue removing traction. See, it's such a large sheet coming out from under the retina, and once this large sheet came out, the retina became mobile. But now anyway the peripheral retina was in tatters, so better I complete the 360 retinectomy. So I did a 360 retinectomy, and finally we landed up with only a small central island, but that's what we could do. But you see that small central island is now fully free of traction, and we just removed the blood, put PFCL. I left this patient under PFCL, and after 10 days removed the PFCL, put in silicone oil, and again in this patient we were able to salvage some vision. So early versus late is controversial. I am a little not a very aggressive surgeon, so I probably don't believe that much in that. But yes, vitrectomy is required once the detachment is there. The vitreous is tenacious. I use an encircling band. The chysis has to be handled. You have to handle the membranes at the edge of the break, the ILM at the edge of the break, and severe cases like I just showed you can have a lot of subretinal proliferation, which you need to manage and do a very, very broad laser. And some of the cases, yes, we will be able to successfully remove oil, and yet the patient will maintain vision. Thank you so much. Now I would request Dr. Vinod also to add some surgical tips.